with that being said, we'll go ahead and get things moving along. So the next session we'll be discussing, this section will encompass knee cartilage restoration as well as various treatments for osteoarthritis. I'll go ahead and get started. So this talk is discussing orthobiologics. And specifically, we're going to focus on orthobiologic management of degenerative joint disease of the knee, so osteoarthritis. So what are orthobiologics? Well, these are biologic cells and growth factors that help mitigate degenerative conditions through anabolic and anti-catabolic pathways, and they have the potential to stimulate a healing and repair process. Really, the agents that we're referring to include autologous blood products, placental tissue products, as well as cell-based products, including bone marrow aspirate, synovial products, and adipose tissue, as well as peripheral blood. If you do a PubMed search for orthobiologics, you're going to see an exponential increase in the amount of manuscripts over the past couple of years. So there's really been a significant invested interest in learning more about and seeing how we can apply these agents. But before we dive too far into the talk, I want to kind of try to clarify a few definitions. This stuff can get quite confusing. The NIH defines stem cells as cells with the ability to divide for indefinite periods in culture and give rise to specialized cells. And they really distinguish themselves by two very important characteristics. One is the capability of renewing themselves, and the second is that they can be induced to become tissue or organ-specific cells with special functions. So this diagram demonstrates those two important characteristics. Even with that being said, though, a lot of this language is very confusing, not only for the lay public, but also for us healthcare providers and orthopedic surgeons. Another definition for stem cell that you may come across would be a homogeneous cell population obtained through culture expansion. And this is different than a cell concentrate, which is a heterogeneous population of cells, only a small fraction of stem cells. So true stem cell therapy includes cells that have been isolated from a pellet of cell concentrate followed by culture expansion, and these are characterized for several parameters, including self-renewal capabilities, expression of specific surface markers, as well as multi-lineage differentiation capacity. Arnold Kaplan is actually the clinician who first coined the term mesenchymal stem cells, and he did this in 1991 while a biologist at Case Western Reserve University. He used this term to describe cells isolated from bone marrow stroma that could give rise to bone and cartilage. However, in 2017, he published this very important paper. It was titled "Mesenchymal Stem Cells: Time to Change the Name." I apologize about how wordy this slide is. However, he states in this manuscript that unfortunately the fact that mesenchymal stem cells are called stem cells is being used to infer that patients will receive direct medical benefit because they imagine these cells will actually differentiate and regenerate tissue, which is entirely not the case. And so as a result, he really stressed the importance of changing the name to medicinal signaling cells because these cells actually operate by cellular signaling via bioactive factor secretion and immunomodulatory effects. However, despite this, I would say that the average person in this country does believe that stem cells is the way that we're going to cure diseases without surgery. However, for all the college football fans in the audience, as Lee Corso would say, not so fast, my friend. Many studies claim to treat knee conditions with stem cells. However, there's significant inconsistency with defining stem cells within the literature. Most current studies are underpowered, under-controlled trials with heterogeneous populations, and most review articles are actually based on authors' conclusions and summaries. So what is allowed in the United States? Well, based on the FDA Title 21 of the federal regulations, we're allowed to minimally manipulate cells. Most commonly that's centrifugation. Homologous use only, so the same tissue function. We're not allowed to add growth factors or enzymes, and does not have systemic effect or is not dependent upon the metabolic activity of living cells as primary function. So what is allowed, what is not allowed? Expanding, culturing the cells, taking the cells away from the operating room or clinic, adding growth factors or enzymes. This is a very busy diagram, but nonetheless, I think it's very important. This is a diagram. It's in one of the manuscripts of Dr. Vagnes, who's really a leader in the field of orthobiologics at Southern California. On the left, you see the most common areas where we're obtaining this tissue: adipose tissue, bone marrow, and then these are minimally manipulated. Really, the two that we're going to focus on in this talk are the fat grafts and bone marrow aspirates. These are minimally manipulated. Over to the right, that's what's not allowed in the United States based on FDA regulation, and that's more of isolation of a particular cell type and further expansion. That's true stem cell therapy. In this review, in this paper, the same paper that I showed you that diagram from, they did a review of the literature and they found extensive variation among treatments, adjuvant therapies, and outcome measures, and treatments didn't necessarily coincide with terminology. So there's a lot of inconsistencies with the nomenclature, how these groups and authors were actually defining their products. I thought this was a very interesting study along those lines. This is from Korea, and they actually looked at 46 studies that claim to utilize stem cell products. And what they found was that vast majority of these studies actually falsely identified the products. 18 studies referred to as an adipose tissue vascular fraction as mesenchymal stem cells when they really weren't. 2 studies referred to peripheral blood progenitor cells as, again, mesenchymal stem cells. And another study demonstrated or claimed that there was a marrow aspirate concentrate, but it actually stated that it was a mesenchymal stem cell. So false claims and inconsistency in the nomenclature. With that being said, let's go ahead and talk about some of the agents. We'll give you a brief overview of kind of what the most common agents that are utilized. PRP, this is whole blood. It's drawn from the patient, centrifuged down. We really have the concentrated autologous platelets suspended in a small amount of plasma, and there's really an abundance of growth factors. And I would argue that this is perhaps the most widely used orthobiologic agent in our field currently. Can treat various muscle and tendon conditions. It's been shown to be efficacious for osteoarthritis of the knee. There's some emerging data that demonstrates that it may play a role in augmentation of meniscus repair, and also has potentially a role for an adjunct to certain meniscus or cartilage repair techniques that I'll cover in the next lecture. Really good data when we're looking at PRP and osteoarthritis. This was a systematic review from a couple years ago, 18 studies, all level 1, significantly higher improvements with PRP compared to HA. Another recent, very high-powered study, this is a meta-analysis, 26 randomized controlled trials. PRP was more effective than HA for treatment of knee osteoarthritis. So really an abundance of literature to support PRP's usage for knee osteoarthritis. Let's shift focus to bone marrow aspirate. Bone marrow aspirate can be harvested from multiple sites. It's processed in a centrifuge to separate the components. It's one stage, minimal manipulation. This is a intraop photo of mine. It's very easy to obtain from the iliac crest. It takes a couple minutes. Usually let the fellows harvest it. Contains high concentrations of various growth factors, and it's really demonstrated to provide a lot of roles in tissue healing and mitigation of inflammatory responses. However, when we dive into the literature looking at BMAC for treatment of osteoarthritis, there's really not a whole lot of supporting studies out there. Not nearly as many studies as PRP. This is a study looking at microfragmented fat compared to BMAC and found no difference between the groups. This is another systematic review looking at 8 different studies and really concluded that BMAC did not demonstrate clinical superiority. Another paper by Filardo from the Cone group from Italy demonstrated an equivalency to hyaluronic acid. However, interestingly, the same group out of Italy, who's really involved with a lot of biologics and preservation types of products and procedures, they did demonstrate significant improvements with subchondral injection as well as intra-articular injection of BMAC. And this is something that our group is currently looking at and writing up. So I do think that there may be a role for BMAC in the subchondral bone. When we look at adipose tissue can be easily obtained, and the amount of mesenchymal stem cells in adipose tissue is significantly higher than the equivalent in bone marrow aspirate. There's really three different derivatives, and really the main that we're going to be focusing on is the microfragmented adipose tissue. So this is minimal manipulation. If we look at this diagram here, it talks about the different pathways that we can process this lipoaspirate. And so microfragmented fat is really what we're going to talk about, and it's minimal manipulation, really the only way we're able to use these cells. This is a patient of mine. I did a pilot trial of 3 patients. It's a very easy to harvest this adipose tissue, and as you can see, very small incision, or in this case, needle stick. This is what it looks like initially, and then this is mechanically washed, and this is the final product here. And this is injected to the knee. I would tell you that I'm currently collecting the 6-month outcome data, but subjectively, the patients are doing phenomenal, all 3 of them. So we'll see what the data shows. Alberto Gobi really did some really nice work looking at microfragmented fat injections. He published this study looking at the Q scores, and what he found was significant increases across the board in all patients. Specifically, there's Kellgren-Lawrence too, so there's mild to moderate osteoarthritis. And as you see based on this chart, he also saw continued improvement in that group up to 2 years. So I really think that's an area where this product could potentially differentiate itself from these other orthobiologic agents. Several other studies demonstrating efficacy for microfragmented fat. We're going to shift focus lastly to amniotic products. Just for sakes of time, I'm going to go ahead and go a little faster here. This is human amniotic membrane. This is a randomized control trial led by Jack Farr, Andreas Gamal, and Adam Yankee. And what they did is they had this amniotic suspension, and they compared this to hyaluronic acid as well as saline. They found improvements with the amniotic suspension, with greater improvements with the amniotic suspension at 6 months compared to the saline as well as the HA. So there may be a role for amniotic products. In summary, intra-articular injections of cell-based therapies, including BMAC, amniotic products, adipose tissue, as well as amniotic-derived products, have potential to improve pain and function in OA. There appears to be promise in the application of cell-based therapies for cartilage repair surgery. PRP is certainly effective for treating osteoarthritis based on high levels of data. Future well-conducted randomized control trials are warranted. And then lastly, be careful with nomenclature. We really have to be specific with how we're defining these treatments. Thank you.